record this. And, and I was in the middle of telling you about the Leszek Madsen resonant voice therapy training courses. Um, the lowdown is basically if we have 15 people in our mentor group and we can't all make the dates that Kitty set um, or suggested, they'd be willing to find a, a, a date or two dates, I
Mhm.
guess, that would work for both the adult and pediatric training courses. And so the student discount is less than the discount for clinicians already in practice, but I think it's still at least $100 cheaper than what's offered online
That would
for
be
the
amazing.
general population. So it's a good deal for us. So the latest is she's asked me to supply names and emails of the 15 people from our Facebook group that are interested in doing the training, and then um, once I get that number, I will forward it to her, and then the people who are organizing the training will reach out to those interested and try to
Oh,
ascertain if the date's going to work. If not, I don't know if you have to be there in person for both days. I'm assuming you do because I
hmm
did my training in person.
hmm
Um, I don't think it's something that you can watch later. I think it's an interactive process.
hmm
Um, so I think that it's worth finding out if there are dates that will work for you so that you can be there for both or all 3 days. And um, yeah, I'm just kind of the intermediary between everybody. So
Okay.
I will do my best to get that moving. I know that the dates are happening next month. So
So do we need to email you our information? Would that be helpful to you?
yeah, if you are for sure interested, um, just send me an email or message me on Facebook and just remind me, say yes, I'm in. If the dates that they proposed work, you can just say I'm in and leave your preferred email that you'd like them to contact you. And then also, if not, say let me know that too.
Okay.
I'll pass
Thank
that
you
on.
very much.
Yes. All right. I think it's the six of us. So um, let me go ahead and start sharing. No matter how much I think I can work this mouse, it doesn't always want to come over to my laptop. Come into the darkness. All right. Can you see my PowerPoint? Yes. All right. So now I just have to get. There we go. All right. Okay. So we're talking about reflux primarily because in a voice practice, I would say that almost every patient has some degree of reflux, especially, well, I mean, pediatrics have a high percentage of reflux issues, and most people over the age of 25 have some degree of reflux. And if you're working with the singing population, an even higher percentage. So it's something that you'll see every day of your clinical practice if voice is your focus. So I don't know how familiar everyone is on reflux, but one of the things that I was shocked by is a lot of times you'll see this kind of diagram showing the esophagus into the stomach, but they're missing a really big part of the anatomy, which is your diaphragm. So I'm going to make sure that you understand and know there's a little gif of the diaphragm and the stomach and where the esophagus connects through the diaphragm, even though they spelled diaphragm incorrectly. I still liked it. So basically, esophageal reflux is considered the most common disease encountered by gastroenterologists, and I would say pretty close second for laryngologists. Contributes to a large proportion of cases treated by primary care providers, but the laryngologists and the GI docs kind of are the ones that generally are making the most of the treatment, hopefully. And what is reflux? Reflux is really just defined as a condition where the stomach contents backflow into the esophagus and or beyond, so even into the oral cavity, larynx, nasopharynx, eustachian tube area, or even down into the lungs as aspiration because of a weakened lower esophageal sphincter. And that can cause some pretty troublesome symptoms and complications. So I found this video from the Mayo Clinic, which I just thought was really nice to go through. It's only a couple of minutes, so I'm just going to play it.
When you swallow food, it travels through a tube called the esophagus. The esophagus leads into the stomach through a hole in a sheet of muscle called the diaphragm. There's a round muscle at the bottom of the esophagus that works like a valve. The muscle relaxes when you swallow, allowing food to pass into the stomach. Certain cells in your stomach, called proton pumps, release acid to help digest the food. The lining of your stomach protects it from the acid. The esophagus has a different type of lining, which looks like it's made of smooth tiles. The valve is designed to close tightly after you swallow, so nothing comes back into the esophagus. Your diaphragm is also meant to pinch securely around the esophagus, closing off the opening to your stomach. It's normal for a small amount of acid to occasionally splash into the esophagus. This is called reflux. That word means flowing back. A small amount of reflux doesn't usually cause any harm. But if acid splashes up into the esophagus over and over again for years, the esophagus can be damaged. There are several reasons this might happen. It's not uncommon for the valve to become weaker, so it doesn't close tightly. That allows acid and partially digested food to come up into the esophagus. Sometimes the diaphragm weakens around the esophagus, allowing the hole to become larger. This hole is called the hiatus. When it becomes larger, part of the stomach may bulge through it. This is called a hiatal hernia. The hernia may cause the esophagus and the valve to move up. In that case, the diaphragm is no longer reinforcing the valve. That makes it more likely that acid will get into the esophagus. When acid and food splash up into the esophagus repeatedly, it's called gastroesophageal reflux disease, or GERD. Gastro for the stomach, or gastric system. Esophageal for the esophagus.
So kind of a cool video that really only goes to the esophagus. So we're just talking about gastroesophageal reflux disease. Which is why I'm going to talk about the difference between GERD and LPR. We'll see both in our clinical caseloads, but voice-related reflux is often laryngopharyngeal reflux, and that's different. So we have GERD, what we just saw in the video, and we have LPR. So basically, I thought this was a nice comprehensive instructional video about how things happen to create reflux. Um, Again, so you've got that basically the lower esophageal sphincter no longer is a one-way valve. Um, and the symptoms for GERD are different than the symptoms for um, laryngopharyngeal reflux. So these are the symptoms for GERD, and I know they're small. We're going to go through them independently. The first one is heartburn. So obviously, when you have the acid burning the esophagus specifically, you'll feel pain in the chest or mid portion of the chest, which is basically following the course of the esophagus. And it's gastric acid, but also pepsin and stomach contents that rise up and irritate the lining of the esophagus. Sometimes lying down and bending over after eating intensifies this heartburn sensation. And a lot of times it's just treated with antacids. If the heartburn is more severe, they might prescribe more stronger medications like proton pump inhibitors or H2 blockers. Regurgitation is also a thing with GERD. And so that's where you might have throat irritation. So food or liquid substances move up into the throat after eating. It can actually be partially digested food, can cause nausea, and it could actually become vomiting, although it's more common, vomiting is more common in children than adults. So indigestion or dyspepsia, also common with GERD. It's discomfort, usually in the upper part of the stomach. Her hands should be a little higher, but include pain, burning, bloating, feeling of fullness, excessive burping, and in some cases vomiting, as I had said. This can happen only after meals, or it could happen throughout the day. Dysphagia, it's usually more of a sensation than a big dysphagia as we know dysphagia. I think that patients with GERD will often feel a sense of globus, and they may feel like they have trouble initiating a swallow, but typical dysphagia is not a symptom of GERD in general. So it's just that initial like feeling that they can't swallow, but they can. So that's basically what I just said. Sore throat. Obviously, if you with GERD you have regurgitation, that the stomach contents will irritate the back of the throat and cause some soreness in the throat and or hoarseness if the acid moves into the larynx. And this is one of the symptoms in GERD that I think gets people's attention, especially singers or voice users, professional voice users. So they're more likely to seek out medical attention with this level of irritation. The bitter taste in the mouth is secondary to the regurgitation or the stomach contents moving up to the throat and the mouth. And it actually can cause some changes in the enamel of the teeth if there's regular regurgitation. So it's I didn't list it in my slide, but it's definitely something that you want to know about with your patients. Sometimes patients will wake up with a bitter taste in their mouth, but oftentimes they get this following meals or if they bend over after meals and they get some regurgitation. Breathing difficulties, again, not really a big symptom for GERD, but if you have acid coming up into the throat that accidentally gets into the larynx. It can cause a laryngospasm. If it goes into the airway, it can cause a bronchospasm, and that can be scary and cause some shortness of breath. People who have asthma and have GERD often find exacerbation of their asthma symptoms with the presence of GERD. So definitely more of a concern with patients who experience asthma. This is not a typical causation of GERD, and we'll talk about the LPR and relating to breathing difficulties in a minute. Increased saliva, I think, often happens because of the regurgitation or the irritation that kind of goes along with the nausea. It's really just the body's way of flushing away the regurgitated stomach acid. So, which also can lead to coughing. When a patient has chronic acid reflux in the esophagus, it can cause sort of a hyperactive response that stimulates the nerve in the lower throat. It can cause pain, and it can cause sort of this kind of co-reactive airway situation. So this is also something that will often bring the patients in for medical treatment. Nausea is listed as one. I think it's just mostly because with the stomach contents coming up to the throat, you get kind of an overactive gag reflux, and it upsets the digestive system globally. And so patients who have this will probably just be recommended to take some kind of over-the-counter anti-nausea medicine. So the LPR is what we will see most of the time, and it's so interesting because it's so multifaceted, and so many symptoms in the patients with LPR are not what you would necessarily think of as acid reflux. So the way we're defining laryngopharyngeal reflux is reflux that moves past both the upper and the lower, well, from the lower up through the upper esophageal sphincters, and enters the laryngopharynx, oropharynx, and or nasopharynx. And we'll talk about later some ear issues associated with LPR, and also some aspiration issues with LPR. But this is a nice diagram. Often you don't see the throat involved with the reflux, so I like this picture. And oftentimes patients don't know they have reflux because it happens when they're sleeping. They get most of the area of the stomach acid going from the stomach, which is at a higher level than the throat. And so acid and stomach contents, mostly pepsin actually, and stomach contents will just pool in the back of the throat and irritate the tissues around the larynx. It can actually even move into the larynx and burn the tissues of the larynx, the oral pharynx, the nasopharynx, and eustachian tube areas. So the symptoms of LPR include hoarseness, which is why we see them pretty quickly, clearing your throat, excessive mucus or sensations of postnasal drip, difficulty swallowing food, liquid, or pills, coughing after eating or lying down, breathing difficulties or choking episodes, troublesome or annoying cough, sensations that something's sticking in the throat, heartburn, chest pain, indigestion. So some of the symptoms are similar to those with patients experiencing GERD, but these are often much, much worse. And hard sometimes to convince the patient that they have reflux because they don't have heartburn. Because basically the pain sensors that exist in the esophagus that give you that sensation get burned off from chronic irritation from stomach contents, moving up past the upper esophageal sphincter. So hoarseness, obviously, we know what hoarseness is when the voice involuntarily sounds breathy, raspy, or strained, or softer in volume, lower in pitch, just not their normal, clear, easy phonation. Frequent throat clearing is often a sign of reflux, and obviously can really exacerbate any edema or erythema of the larynx, of the vocal folds in particular. So when you have patients who have reflux and they're clearing their throat all the time, one of the things I think we talked about early on was teaching them to do a silent cough. Get the mucus up to a place where they can swallow it and then swallow it, where they're not creating a collision of the vocal fold edges, which creates, the brain thinks that there's an injury on the vibratory edge and more mucus is sent to that area. So it's a very vicious cycle, especially with these patients. So that's a really important thing to remember about the throat clearing. Excessive mucus and postnasal drip. I found this little poster about treating postnasal drip. It's not actually postnasal drip in the sense of sinus congestion running down the back of the throat. When the tissue in the back of the throat has been irritated by stomach contents, the body again secretes mucus to protect it from being burned. And so you have this sense of postnasal drip, but there isn't anything to blow out of the nose. So it's another tricky symptom of LPR. Often patients are perplexed by that they sense this thick mucus, but they don't really have any discharge out of their nose. Dysphagia with LPR is a different story. It is sometimes an irritation that does prevent or delay the onset of swallow. And also, once a bolus is introduced into the esophagus, because of the damage to the tissue in the esophagus, there's often scar tissue that constricts the esophagus, so there's less space for food and liquid to go down. So it often will get stuck kind of mid-chest and be kind of a scary experience for a patient, as they can't really get it up or they can't get it down. So sometimes patients need dilation of the esophagus to improve their symptoms here. Obviously, we know that difficulty swallowing is also related to other more serious issues. So if you have a patient who has this issue, ruling out a tumor in the esophagus or other neurological disorders is important. Cough is another big deal for all the same reasons of GERD, but more specifically, the areas of the throat are much more involved with LPR. And this happens sometimes while eating, post-meal, or with lying down, and especially at night when sleeping. And the breathing difficulties for patients with LPR are actually more related to laryngospasm with acid burning the vocal folds, and the vocal folds going into laryngospasm, and some aspiration into the lungs or airway, and some chronic airway irritation or hypersensitivity. I think because of all of that chronic irritation, as high up as it is in LPR, there often is a sense of something irritating the throat at all times, and that could just be the chronic irritation and changes in the tissue in the throat. So the heartburn doesn't really exist in LPR. It occasionally a patient will say they have some experience of that, but often it's more related to breakthrough heartburn when they're on proton pump inhibitors, or they've taken it for 3 months and they go off and they have breakthrough heartburn, but not generally while they're experiencing LPR. More likely, it's going to be a voice symptom, hoarseness, decreased range, fatigue, scratchy throat, those kind of things. This is a nice chart again, just kind of contrasting esophageal GERD versus supraesophageal, which is the same thing as LPR. So you're more likely to see so many other systems at play here. So LPR-induced asthma is a pretty big thing. And over the last decade, I think there's been some really great research that helps us understand this. There are two ways that acid reflux can trigger asthma or make the symptoms worse. One is just the irritation of the nerve in the esophagus. So this sets off a chain reaction. Your brain tells the airway to protect from acid, so the airway is narrow to keep the acid out, and then the asthma symptoms either are exacerbated or begin. And then the other is actually getting acid into an aspiration situation where you've got the lung tissue irritated, so the acid is irritating. And I'm saying acid, but I really mean stomach contents, because we also know now that it's less about stomach acid and more about pepsin, sometimes bile, and sometimes other agents in the stomach. But they irritate the airways, make you wheeze, cough, and feel tightness in your chest. So kind of a really, really, really interesting new understanding that you may not have ever had asthma in your life, and then you can get asthma from having LPR. And here are some of the ways of knowing whether your asthma is related to LPR, and this is good to know for your patients. So your asthma symptoms start when you're an adult. Your asthma gets worse after you eat, exercise, or lie down. Asthma treatments don't really work very well for you. You cough often or have a hoarse voice. So those are all really important things, and I just think that it's not a common knowledge base. At least it wasn't for me. So I hope that this is helpful to you. LPR-induced sinusitis is also kind of an emerging area of understanding with reflux as well. And so this is just a little picture of what sinusitis looks like and what the sinuses look like normally. You've got the one side of clear sinuses and the other side of kind of pussy, inflamed sinuses. But it actually can be that you have sinusitis secondary to LPR, as the acid can travel all the way up to the nasopharynx and sinuses, especially while you're lying down and asleep, and the acid inflames the nose and the sinus linings. So this is one of the main reasons that I tell my patients who have LPR to get the head of their bed elevated at least 5 inches so that they have a higher head position than their stomach, and that just simply takes this issue out of the picture. So chronic cough obviously is something that we deal with as on a regular basis as speech pathologists, but just understanding the mechanism behind LPR and chronic cough is helpful. So really the direct stimulation of the laryngopharyngeal mucosa by the enzymes and stomach contents, and the vagal reflux evoked by reflux in the esophagus are a big contributor, and then also laryngopharyngeal inflammation or laryngopharyngitis. So one of the things that is talked about a lot is avoiding exercise after meals or lying down after meals, so that you don't have extra irritation and increased chance of coughing. So LPR and aspiration pneumonia, obviously aspirating gastric refluxate is one of the most serious variants of LPR, and its complications are difficult to diagnose and treat. So this is also an important challenge for children. Children and infants in particular tend to manifest with cough, hoarseness, stridor, sore throat, asthma, vomiting, globus, wheezing, and recurrent pneumonia, just because their vocal tract and their throat's shaped, more open than an adult, so they're more susceptible to these kind of complications. I, of course, have to throw in some pictures of the larynx. And sorry if these aren't the greatest pictures, but can you see kind of this grayish, thick band between the arytenoids here? So that is what we call pachydermia, after the elephant. I call it a scar band, but basically that tissue is not supposed to be there, and it's caused from chronic irritation. And you can see the red and swollen arytenoids here at the vocal process as well. Not as much on the vocal fold in this particular area, but in general, the larynx looks a little swollen. So this person probably has a sore throat, irritated voice, probably some hoarseness, definitely needs to be treated. Here we have almost blister-like changes in the mucosa on the vibratory edges, and varices that are very pronounced. The anterior commissure is really red as well. You can see kind of this whole band of redness, and you've got the arytenoids like really red. Obviously, none of this is normal, and we can't see the inner arytenoid area because of the posturing of the arytenoids here, but I'm guessing that this would be pretty cobblestoney and pachydermia-like. And then here is one of the reddest larynges I had seen, really almost bloody red, very, very irritated, all of the mucosa and tissue around. You can see thick mucus developing on the vibratory edges here. I'm surprised that the cords look as good as they do in this condition. But you've got the pachydermia, the swelling, the redness. There's maybe even a little tiny lesion starting here. I don't know if you can see that or not. And that little lesion can grow up to be this little lesion, which is granuloma. And its etiology is reflux. Often this is a surgical case, as you can imagine. This person has quite a complicated set of tissue changes. But yeah, that's what a granuloma looks like. And obviously this person has crazy tissue changes throughout the larynx. So this also is kind of a new development of understanding that for some people, LPR and nasopharyngeal reflux can lead to ear pressure and ear pain, often in the form of eustachian tube obstruction. And it can be pretty painful, and it can radiate into the jaw or just the ear itself. But it's definitely something that you want to consider if you have a patient who has a known diagnosis of LPR and they're talking about ear pain and wondering if they have a ear infection. So generally the symptoms are ear pain, a feeling of fullness, hearing difficulties even, ringing or popping noises, and maybe even dizziness because of the pressure regulation that's impacted by the obstruction of the eustachian tubes. So really what happens here is the pepsin reaches the ears through the eustachian tube and causes inflammation like it does everywhere else. And then you can have quite a bit of pain in the ear. And again, children are especially susceptible to ear pain from LPR because their eustachian tubes are not fully developed yet. And the pepsin can pass through that area easier. So the treatment typically for LPR and reflux, but mostly GERD, but mostly LPR is a proton pump inhibitor. The common ones you'll hear are Nexium, Prilosec, Prevacid, but the list goes on and on. H2 blockers, and the common ones are Pepcid and Zantac, although Zantac was pulled off for cancer-causing changes, so we don't want our patients taking Zantac. Antacids, sometimes all three of these are in the play with the treatment program. Gaviscon is my favorite antacid choice. Tums don't really do as much as far as creating a barrier, but they do work as an antacid. Lifestyle changes. So I talked a little bit about the elevating the head of the bed. The GI doc I talked to said 5 inches is therapeutic. And so I always pick the lowest amount of height change for patients so that they're more likely to comply with that part of the lifestyle change. Some people use a really high wedge and they're up like a ski lift and they end up slid down to the bottom of the bed by the end of the night. So I found that there are bed risers at Bed Bath & Beyond that you can stick under the legs of your bed on the headboard side of the bed. And that's about 5 inches, and it's an easy thing to do and remove if the symptoms abate. So that's what I recommend for my patients. There are also, I think, whole mattress kind of wedges that don't end up bending you in the middle, which is obviously not a good idea to have increased pressure on the stomach. So that's also a good idea as one of the full length of the mattress gradually inclined toward the head. Stopping eating and drinking 2 to 3 hours before bedtime is also a really great idea. It takes about 2 to 2.5 hours for the body to digest food. So that gives you time for that process to be completed before you go to sleep, which means you'll have less in your stomach to irritate the back of your throat. Smaller, more frequent meals is often recommended. Avoiding heavy, fried, and fatty foods is often recommended. Eliminating alcohol is often challenging to get the patients to do, but if you can explain to them that that alcohol relaxes smooth muscle, which is what our digestive system is lined with. So if we're drinking alcohol, we're already creating acid reflux potential just by relaxing the lower esophageal sphincter. Losing weight is often recommended. Avoiding caffeinated and carbonated beverages is also sometimes recommended. The carbonation can increase belching, which can sometimes induce regurgitation, but the caffeine also stimulates stomach acid production. So surgery is usually the very, very, very last step. So the role of the speech pathologist is to make sure that the patients are taking their medications correctly. And this is a big deal because I have had patients get a prescription for a proton pump inhibitor, and the proton pump inhibitors are really snarky medications. They need to be taken on an empty stomach, and then you need to eat something about 40 to 45 minutes after you take the medicine. It doesn't have to be a meal, but you need to eat something to initiate stomach acid production. So I've had patients say they take it at bedtime, which the proton pump doesn't really work or isn't active at while we're sleeping. So that's just kind of a big old waste of money. Or sometimes they'll take it with breakfast, which again, you're not getting the benefit from the medication. So really understanding how these medications work and making sure that the patients are taking them appropriately helps them actually get treatment from the medicine they're taking. Emphasize the behavior modification. So if you can get a person to go to bed with an empty stomach, and that means no food or drinking even water, then they don't have anything to irritate the throat. And if you get the head of the bed elevated, even if they have something in the stomach, it can't get to the throat. So really, really easy ways of fixing the mechanical problem. And this is a great solution for patients who are really against taking any kind of medicine. So I highly recommend stressing that. I think also really playing the vocal hygiene card and making sure that their vocal environment is as healthy as possible. If they've already been dealing with a chronic irritant, we want to baby the tissue and the vocal fold mucosa as much as possible. There will be likely some muscle tension secondary to kind of bracing for the chronic irritation in the throat. Even though we don't have pain sensors on the vocal folds, the body knows that there's a chronic irritation. And so oftentimes there's an underlying muscle tension dysphonia that goes along with having chronic LPR. And then, we might have patients who have granuloma who need surgery to remove them. So really getting them prepared pre and post, and then return them to normal voicing post-operatively, an important strategy. So here are questions, but I also have, and I can just end this here. Interestingly, there are two types of Gaviscon that exist. One is the US version. The other is every other country in the world. And the US version has aluminum in it, which may or may not be problematic, but there is some question about the role of aluminum in Alzheimer's disease. It does create a barrier. It does work as an antacid, but there's that extra ingredient that I thought you should know about. This actually targets pepsin, and that's what we're dealing with LPR. So you can order this. My friend just brought this back from Germany because she went to visit her family, but you can order this on Amazon. So just know that is the better choice for the patients with LPR. Any questions?
Two things. You said that the Gaviscon International does not have the aluminum in it.
Correct.
Okay. And then is that like better than taking the proton inhibitors or the H2 blockers? Is there a preference as to all three of those, which is one is sort of safer long term and vocally?
Definitely. Back in the 80s and 90s, doctors were prescribing proton pump inhibitors like just forever. They didn't ever take their patients off of them. And now we know that it can lead to osteopenia and calcium absorption issues and maybe even dementia. So 3 months is about as much time as any patient should be on a proton pump inhibitor. If you have somebody with ulcers, ulcerative changes in the esophagus, or esophageal lesions, a GI doc is always going to put the patient on a proton pump inhibitor for a minimum of 3 months, sometimes longer. But for a patient with LPR, often if it's severe reflux, like a 3 or a 4 on a grade, it will be common for a physician to put a patient on proton pump inhibitors initially, but maybe only a morning, like before breakfast, proton pump inhibitor, and then they'll utilize something like a Pepsid AC or a Pepsid Complete at bedtime, and maybe even a little adjuvant Gaviscon after meals during the day. Or for me, I sometimes will chew one Gaviscon if I have to sing like for 2.5 hour rehearsal or something, because sometimes, well, most of the time our rehearsals are after dinner, but not like 2.5 hours after dinner, more like a half an hour after dinner. So I will often chew a Gaviscon before singing, and I think that that's more the trend now. That if you are going to be on a proton pump inhibitor, it's usually the smallest dose and coupled with an H2 blocker, and some antacid. And I think ultimately, like, I am just a Gaviscon and a Pepsid at night girl. But but I think it's common to see your patients being on all three, depending on the severity of their reflux. But it's a good question to ask them, how long have you been on your Prevacid or Prilosec or Nexium? Because they might say 3 years, and then you're like, let's see if we can talk to your doctor about rethinking the treatment plan, just so you can advocate for your patient.
Thank you.
Yeah, Susan, hold on. I'm just trying to move this down so I'm not looking up at you here. Someday I'll figure this out. It's my husband's setup, and he doesn't have a mouse pad, so I'm like lighting it on the desk. It's not always working. All right. Well, I'm sorry I'm looking up at you, but here.
Okay, it's okay. I had heard, like, back when I was in school in the 90s, that the GERD, one of the risk factors of having untreated GERD was that it could create cells that were precancerous. So that definitely still is holds true.
Yeah, it is, and that's why it needs to be taken seriously. And I think esophageal cancer and laryngeal cancer are potential outcomes from untreated chronic LPR or GERD. Not so much GERD, but LPR for the laryngeal cancer. I had a jazz singer who ended up with laryngeal carcinoma at a very, very early stage, and she's fine now and she's singing and she's been great. But that was really scary for me, it was the early in my career eye opener of like, oh, reflux is something to really take seriously. So yes, good question.
Yeah.
How many of you have had patients with reflux that you've been working with? Pretty common. Um, have any of you had any patients who've had to have surgery? We didn't really talk about the surgery for reflux, but have have any of you had any patients who've had the fundoplication? Yes. Okay. Claire, how did they do post-operatively?
I think for me, reflux can be such a beast. Like GI issues in general are such a beast because there's certain things that can help with symptoms or certain things that, make the patient more comfortable, but it kind of feels like it never really goes away.
Yeah.
Like, and it's like, I used to have this, the diet talk, like, oh, well, what are you eating? Like, what are your triggers? Like, what's making it worse? Like, talk about lifestyle changes, all those good things. But for certain patients, it just feels like you're just constantly like chasing after it and it never really like fully goes away. Um, and then it's like once they get a fundoplication or it just there's always like some other complication around the corner. It feels like with the GI crowd.
Yeah. Yeah, I agree with that. And also, I think that there's kind of a little bit of a ego struggle between the GI doc and the laryngologists
Mm-hmm.
as far as who should be treating it more. But yeah, I think, and also the hiatal hernia can be a really big deal. But because of where that weakness is and the pushing up of the stomach through the diaphragm, it's not really operated on very often because of what you're dealing with your breathing muscle, your lungs, your heart, all of that right there. So it's once you have that diagnosis, you're pretty much you're dealing with it. Yeah,
Yeah.
it's funny too that the diet recommendations are so like driven by the understanding that it was acid burning the back of the throat, and the Western medicine hasn't really caught up with the recommendations based on what the research is telling us. So I think that can also be challenging. Like you'll often hear avoid acidic foods, and that's not always the case, especially how acidic foods kind of can become sometimes alkaline in the body. So it's always so frustrating and confusing to try to marry the Western and Eastern medicines together around reflux. And you definitely have, I think, probably more and more now emerging patients who just don't want to take medicine. They only want to do the naturopathic solutions, which, I mean, you can tell them going to bed with an empty stomach and elevating the head of the bed requires zero medication.
Mm-hmm.
But also, deglycerin, deglycerinated licorice is supposed to be good. Aloe vera juice can be helpful in healing mucosal injury.
Mm-hmm.
So those are just some things that I've kind of researched. But any other ideas that you guys have come across?
This is called enzymatica. It's a digestive enzyme.
Oh, okay, yeah.
And because some people feel that taking things like Pepsid like stops the body from naturally sorry, I don't know all of the verbiage, but stops the body from naturally like um, being able to deal with the acid.
Huh. Um,
That being said, I'm not sure this works or the I
right.
mean, honestly, or the DCL or the aloe vera juice. I'm like, I'm not
No, I
sure.
know.
Yeah.
There isn't a whole lot of research out there, is there? I think if you think it works, there's a good chance it does, right? Um, but yeah, I think the the difference between the proton pump inhibitor, which actually reduces the amount of stomach acid that you make, and the H2 blocker, which is a histamine blocker, um, it's just they're two different mechanisms. And then I've heard it said that one of the problems with reflux is that we don't have enough stomach acid in our body to break down. I mean, there's so much misinformation. It's sort of like dealing with the all the myths in the singing world. It's hard to navigate sometimes, but this is the information that I know that is actually evidence based.
Mhm.
Um, and I think, we'll probably learn more and more as more things are researched. But I sing with a GI doc, and she said basically none of this medication is changing the fact that we're refluxing.
Mhm.
So if having that reflux creates an environment that is problematic, then maybe you need to stop the reflux from happening. And that's why she's also a surgeon. But I don't know. I don't know that I'd ever want to have a fundoplication. I had a voice teacher have one and ended up in the ICU because they made it too tight and she
Mhm.
couldn't
She couldn't
um,
eat.
couldn't eat. Yeah, she
Mhm.
couldn't. So I don't know. It scares the heck out of me. But at
Yeah.
least we know. Um, I will put the video just because I think it's a good patient teaching tool. I'll put that in the Google Drive. I also have a reflux symptom index sheet in the drive that you can use with your patients just to kind of get a baseline of where they are when you have them for your evaluation, and then you can kind of revisit that towards your discharge and just see where they are, just so that it's something that they can continue to think about. But
Is GERD, Kate, is GERD and LPR, is that part of normal aging so that the older you get, the more loose the sphincters will be?
I believe so. I think that starting around age 25, that lower esophageal sphincter starts to weaken a little bit. Um, and I mean, it all depends too on your level of activity and if you're overweight or not.
Mm.
But definitely the sphincter becomes less of a one-way valve and more of a two-way valve as we get older. And I think singers have, because of the increased intra-abdominal pressures associated with support, we often can have higher incidences of reflux because of that. So, and also I think sometimes um, we tend to eat late at night after late performances and go to bed, and so our life, and probably with pizza and wine. So we're not always, the lifestyle isn't always the healthiest with singers, and I'm talking myself included. So yeah, but I think aging is a consideration for sure. And esophageal cancer is something that we need to be aware of, and just kind of look out for our patients regarding their symptoms and make sure that they're being followed up with a GI specialist and not just the laryngologist, so that someone is actually looking at their esophagus with an upper GI. Really important thing. Um, feel like there was more I wanted to say, but
I'm sorry, I just had a question. Did you say that you take the Pepsid at night and then you take the Gaviscon between meals? Is that what you had said?
that is what I said.
Okay, thank you.
So I will take I don't really eat heavy meals except for dinner. So
Mhm.
I will have Gaviscon like before my rehearsals in the evening, and then I'll take a Pepsid at bedtime.
Mhm.
But I think every laryngologist or ENT or GI doc has their own protocol that they like to follow.
Mhm. Mhm.
Um, One of the things I thought I had, I guess in the handout, for those of you who work in peds, I have a little at the bottom of the handout. I have a little picture that talks about things that to think about with the pediatric population. So you can have that. I had fun making my little handout. I did add all of the papers that I came across while I was researching this, so that you just can see kind of where I'm drawing this information from. It's it's not all from my practical experience. It's a lot of it is I just wanted to make sure that I was sharing with you the latest and greatest info. And there's actually some pretty good new research out there. So
When you elevate, is there any issue with elevating the bed with those bed risers in terms of how it affects posture or muscles or achiness, or is there any like problem with that?
I I don't know the answer to that actually. I think that because you're elevating the whole mattress, that you're still on a flat surface. You're just
I see.
angled. Um, but that's why I always recommend like the smallest elevation of 5 inches that is therapeutic. Because I mean, I'm sure that if you're up like this and you're sliding down all day and trying to like reach yourself back up to your pillow, that can't be good for your quality of sleep or anything else. So
Mhm.
I'm guessing it's not the best for you. But I don't know. I actually don't sleep with an elevated head because my reflux isn't an issue that I'm other than what I do to ameliorate it.
Mhm.
So, but that's a good question. Anyone else have a patients who deal with that and complain of achiness or no?
No?
Okay.
Okay.
I don't know. I didn't see anything in my literature review that stood out as don't elevate the head of the bed because you're throwing off. Now, one of the things that I do know is that some people will be creative and elevate the head of their bed by adding more pillows, and that can definitely impact the cervical spine
Mhm.
by being way out of out of its normal alignment and posture. So I think the creative versions of elevating the head of the bed are more problematic than getting the whole mattress elevated,
Mhm.
so that you're still on your flat surface that way.
Thank
Like
you.
I always ask my patients, how are you elevating the head of the bed? If you say you're, like, what is
Mhm.
your solution? Because, yeah, we don't want them to mess with the muscles in the head and neck because that's also something that we're dealing with their voice production. So if they're reinforcing the tension every night when they sleep, we have an uphill battle for
Mhm.
sure.
Okay. Thank you.
You find that people did do actually elevate the bed. When I was working in the 90s in an ENT's office, we would suggest that, and I would say more than half people just didn't even do it. They were resistant to it. They did not want to do it. They wouldn't even try it.
I think that's probably low estimation. I think that, I mean, I don't know for sure, but I have a feeling that only maybe 15 to 20% of patients actually elevate the head of their bed because they say, oh, my partner will never handle that, or, I don't like the feeling of that, or blah, blah, blah. I mean, there's always some excuse, but I don't think many people go for that option, which is actually one of the easiest things to do. But yeah. Does anyone here have the head of their bed elevated? Do you, Anne? All right. How do you have your bed elevated?
I actually, we got one of those sleep number beds, so it adjusts. And oh, hi Bear. Um, and I have terrible reflux, so I was using a wedge pillow. Um, and then we splurged and got a bed that it elevates. So it's nice because I can like set it to elevate, and then after, 3 hours, it can go a little flatter.
Nice.
Um, yeah, it's nice. I have to say it has helped a lot. And posture issues, it's better than when I had the wedge for some reason.
Can you sleep on your side or on your stomach?
Yeah, I've gotten used to it. Like I only elevate it, 5, 6 inches, but I've gotten used to sleeping on my side and even on my stomach that way.
Wow.
Um, yeah, I don't know, but
Maybe that's the solution.
yeah, yeah,
Everyone needs to splurge with a sleep number bed. I'll have to remember that next time.
it is worth it for sure, I must say.
Well, the older you get, the more it becomes an issue. I think Susan's right. So enjoy your youth, all of you. um, all right. Let me just look at my handout real quickly just to make sure I'm not forgetting anything. Um, I do talk a little bit about the fundoplication, and TIF is the new transoral fundoplication. So it's a less invasive form of fundo, which would probably be my choice. The reflux
So they go down through, oh my gosh.
yeah.
Wow.
And we thought the scope was, you know. Oh, so I'll go over the reflux symptom index with you. So I purposefully left the link to the University of Iowa. You'll see on the top it says return to extraesophageal reflux disease at the top of the handout, and that gives you a direct link to the original research behind this index. So basically, there are 9 questions, and you've got a scale of 0 to 5, 0 being no evidence of a problem, and 5 is a severe problem. So the categories include hoarseness or a problem with the voice, clearing the throat, excess throat mucus or postnasal drip, difficulty swallowing food, liquid, or pills, coughing after eating or lying down, breathing difficulties or choking episodes, troublesome or annoying cough, sensations of something sticking in the throat, and heartburn, chest pain, indigestion, or stomach acid coming up. So it's pretty much right out of the research, which is where I got my categories for the slides as well. So that was made by Bolofsky, Postma, and Kaufman. And Jamie Kaufman is a laryngologist. She was out of Florida, but I think now she's somewhere in the South and another state. And she's written a book. I actually just downloaded it on my Kindle. That I've had some patients read and follow. It's and they've had great success with it. It's called Dr. Kaufman's Acid Reflux Diet. and she's got 111 recipes, including vegan and gluten-free. So, if your patients want to go the dietary route, I don't have any specific research, but I have had anecdotal reporting from patients saying that's made a big difference. In fact, one of my patients who is a singer, professional singer, she followed it and she said she got down to the weight she was in high school. So that's one of the reasons I bought it, actually. I was like, oh, okay, maybe I'll look at that. But I think in my own experience, if I minimize, I don't really do well with gluten in general. So not eating gluten definitely changes the incidence of my reflux symptoms to a lesser degree, obviously. Also dairy. But I have some weird triggers like green peppers. So, I mean, I think everyone is a little bit different with their triggers, and that's something too that you can just talk to your patients about. Dr. Opperman, who's a laryngologist that I work with often, suggests to patients that they switch from red wine to white wine or beer because it's less acid and tannin in the white wine and none in the beer. But I don't know. That's a hard thing to do. Red wine is so good. But let's see what else. And then, we didn't really talk about the singing voice symptoms, but singing voice symptoms, in my experience, are often fatigue, more like throat pain, hoarseness, voice breaks that they didn't have before, which kind of also leads to like difficulty singing through register transitions, decreased range, and that's maybe secondary to muscle tension, vocal fatigue, I think I said, tightness in the throat, again, secondary MTD, throat clearing during singing, excess mucus during singing, prolonged warm-up times, and kind of a foggy voice in general in the morning. And that's pretty consistently true for singers with LPR. So that's in your handout too. And I put in the pictures from the slides of the vocal folds with the LPR changes. And then the silent reflux in infants and children part of the handout. Silent reflux is especially common in infants and in children, and they have persistent cough, reactive airway disease / asthma, difficulty with weight gain, hoarseness, stridor or loud breathing, apnea or pauses in breathing, trouble with feeding, a lot of regurgitation or spitting up, and aspiration of food and liquid. So for those of you who work in a pediatric population, it's a whole different level of issues with these kiddos. How many of you are in peds or want to work in peds? Okay, just Lauren. Well, you'll have that in there for you. And that actually came from, I left drjockers.com. It's actually, he has this whole really interesting blog. I don't know how I didn't have a chance to look at all of the information, but it was quite a bit of information. So I thought it would be interesting even to have you look at that if you wanted to. All right. I think that's all of the pertinent info. Any thoughts about how long you? I think that was another discussion I was having. Well, when my internet went down. Do you have interest in continuing this through the calendar year? Would you like to end it in the summer? What sounds good to you?
I will keep showing up as long as you keep doing it. So
Okay, all right.
I'm first.
Yeah.
Same.
Yeah, I agree with that also.
Okay. Um, and great. I mean, I'm planning on at least through the end of the calendar year, twice a month. It may be that I can keep going. We have been sailing for 6 months out of the year until COVID hit, and then we sailed as far as New Zealand, and then we came home to check on my folks and weren't able to get back in. So our boat has been in closed borders in New Zealand, and we'll be able to get back there in January. So I don't know what my internet situation is going to be, but I think if we use Google Fi, we can have international internet wherever we go, and then I should be able to keep doing this, which I really enjoy doing. You guys are great, and it's fun to share. And I also, when I kind of research the topics, it's fun for me to get excited and learn new information and then pass it along. So I'm enjoying this. Well, I know it's getting late for some of you, so have an awesome rest of your evening. I will put the recording up usually in a day or two, and the handout's there now, along with all of the research that I gathered in my lit review. And if I randomly throw things in there that I think you might be interested in. So if for some reason you don't have access to the Google Drive, I think all of you are on there. But just shoot me an email and I'll make sure you're an approved user viewer. Okay. Thanks
All
for
right.
being here, everyone.
Thank you.
Thank you, Kate.
I'll
Yeah, thank
send
you
out
very much.
probably this weekend too. I'll send out one available for April
Awesome.
so we can plan those dates in advance.
Great.
All right.
Okay,
Thank
thanks.
you very
Thank
much.
you.
Good night.
Thank you for
Thank
your
you.
Bye. There we go.